So for tonight, I want you all to please thank, we can't do our programs without getting supported by those in the pharmaceutical industry who really, really want all of our audiences to learn from our programs. And so we reach out to get support from pharma. And for tonight's program, I want you all to thank Sanofi Genzyme to start with. All right, round of applause, everybody, for everybody. All right, then we have Biogen. All right, EMD Serono, Celgene, Mallinckrodt, and Novartis. And I want you all to say thank you to all of them for allowing us to do this tonight. Great, perfect, thank you. Next up, we have our next speaker is Gary Owens. And Gary Owens comes from afar to educate you all on what he's going to be speaking about tonight. He's a primary care physician by background. Gary is Dr. Owens, I should say, is a former vice chairman of Department of Family Medicine at the Medical Center of Delaware. He's a former VP of Medical Management and Policy at the Independence Blue Cross. He's authored over 125 publications, including a dozen on ergonomic or economic and payer management and MS treatments. I'm not going to say more about him. I'm going to welcome him up. He's got a lot to speak about. I want to give him all the time to do this. Let's welcome Dr. Gary Owens. Thank you.
All right, first and foremost, thank you all for being here. It's great to talk before a group like this. And Stuart, thanks for that kind introduction. What we're going to do today is I'm going to do a little personalization of what we're going to talk about and then take you into the world that you probably don't spend a lot of time in except when something goes wrong. And that's the world of insurance, right? Now, raise your hands. How many of you have read your health insurance, or for that matter, any other insurance policy you own, cover to cover? We got a couple of people out there. I used to say 90% of the people have never read it, right? And 10% of the people lie about it. But there are a few people who have actually read it. So unlike most of our speakers that are here tonight, I don't have MS. However, I do have some very close family members, both a niece and a son, diagnosed with MS, and I've been through the journey with both of them. So, this is what we're going to talk about. I'm not going to read this slide side by side, but what we're really going to talk about is a bit about what happens when you get diagnosed, what happens when you get a prescription, what are some of the basic things you need to know about insurance. There are terms out there that you've never heard before and never had any reason to hear before. And really then, just talk about, some of the agencies and organizations and others that may become involved in your care other than just you and your doctor or your therapist or whomever you're working with. But first I'll go back in time to about 3 years ago when my otherwise very healthy mid-30-year-old son began to have some unusual neurologic symptoms. And of course, like many of you out there, he wasn't diagnosed quickly, but eventually came to have the diagnosis of MS. I got him connected with an MS specialist who I thought would be very appropriate for him and his type of personality. It's in our area, in the northern Delaware, southeastern Pennsylvania area. And then he got his first prescription. Now, you have to characterize this by the fact that I was a practicing primary care physician for about 15 years, worked in the insurance industry in the Blue Cross system for another 25 years, and have been a consultant to the industry, including drug manufacturers who make MS drugs now for more than a decade. Now, before you do the math, I started all this when I was 4. So, don't add all that up too quickly. But, he brings his first prescription from the doctor's office with him, and he goes, "Dad, what do I do next?" My first answer was, "Oh, no." It was basically, this is not like, you can take your prescription, you can walk down to the CVS on the corner, hand it to John, the pharmacist, and wait 15 minutes while your prescription gets filled. This is going to be a process where your doctor's very likely going to have to talk to your insurance company. Your insurance company is very likely going to have some rules around, what medications you may and may not have covered initially. And you're very likely going to have to deal with an array of folks, a specialty pharmacy, a case manager, perhaps an RX hub. And he goes, what are all these? So that's really the type of journey that I kind of want to walk you through tonight. You know, first of all, I'm not telling you anything you don't know here, and we have MS experts that are going to talk to you later in the night. But there are lots of treatments that are available for MS. I think at last count was at 17 or something close to that. It may even be more than that now. Your care is a lifetime of care. You're going to be investing not only your time, energy, and effort, but your caregiver's time, energy, and effort over a lifetime. These medicines are not designed to cure your disease, of course, but they're designed to mitigate the progression of your disease and to prevent exacerbations. And the choice of many of these treatment options is an individual or personalized decision between you and your physician, hopefully through a process that we call shared decision making, where physician gives you information, you have the opportunity to ask and get questions answered back and forth, and settle on a treatment that seems to be most appropriate for you. So that all happens in an ideal world, right? In the real world, getting that new prescription filled is not always that easy. The reality is these are expensive therapies, right? And those who have to pay for that care, which we're going to talk about in a few minutes, begin to ask a lot of questions about the expense of these therapies. And I tend to think of the U.S. healthcare system. We have a wonderful healthcare system in this country, and there's a lot of buts. It was put together over time and with a whole lot of little pieces that we put together. And can you imagine building a car, starting with something in one corner of the country and another thing in another corner of the country, and 5 people making yet another part, and they all come together in a functioning car? Well, that's about what happened in the U.S. healthcare system, except one of the things we forgot in all of this was the brakes, right? Because in the U.S. we spend about 3 times as much money per person on healthcare as other major industrialized countries. So, and unfortunately, the payers, became the de facto brakes in the system, which is not always a way to be made the most popular in the system. Why do payers care about MS treatments? There are not that many MS patients compared to diseases like diabetes and asthma and heart disease. And why payers care about this is illustrated. I don't want you to focus on that graphic on the slide. I just want you to focus on the stair steps going upward. This has been a relentless increase in the cost of therapy over the last couple of decades. And just over the last 5 years, you can see the increase in cost of these therapies. So those who pay for your care, which are really, 3 sources, governments, your employers, and you, all begin to ask questions about, am I getting the right thing at the right cost? And in a lot of times, if we've already said, MS therapy is personalized. Also, payers make a big lifetime investment in the care of an MS patient. In fact, in some data we published in the Journal of Managed Care Pharmacy a few years back, the total lifetime cost of an MS patient in 2010 is close to $4.1 million. Now that varies, that's an average, because it varies about when you're diagnosed and what your treatments are. But it's a very large investment, so there are a lot of questions being asked about the cost of these therapies. In addition to that, does anybody know what the most expensive medicine is? The most expensive medicine is one that's paid for and not taken, right? Whether it costs 10 cents or $10,000, because you get no benefit and only are paying for it. And so payers understand that adherence to medicine, not only in MS, but in other chronic diseases, is an issue, and payers want to work with that. So I do that up to tee up that, among other things, payers will become involved in your care. Now, the next question is, I've just said something that many of you may not know what it is, and what is a payer, right? We're going to start with the basics here. All of these terms are terms that get thrown about in the insurance world, both health insurance and others, and it can be a bewildering array. So let's start with the basics. What is a payer? Well, in simple terms, in the dictionary definition, it's somebody who pays for something. In the healthcare world, it's an organization which really manages the financial and the operational aspects of providing your care. So payers don't prescribe, that's up to the physicians, right? Payers don't consume health care, that's up to you all and me and everybody else who consumes medical care, but they pay for it and they manage the process of paying for it. And who are the biggest payers in the U.S.? Well, number one, we are, right? We are because we pay taxes, and the federal and state governments pay for about 50% of health care in this country. And that's through Medicare, Medicaid, the children's insurance programs, and other various subsidies out there, like for the individual health care programs. The next largest payer for health care in the United States is the employers. For those of us who are working for a living, your employer is paying for the majority of your health care, or at least it was paying for the majority. You're all seeing fewer and fewer benefits from employer-sponsored health care. And then the last payer, obviously, is private citizens like you, me, and everybody else in this room. Private citizens pay somewhere between 10 and 20% of the health care bill in the U.S. What is a benefit? Payers pay for benefits. And what is a benefit? These are the 10 essential health benefits that are mandated by the federal government in all insurance plans. And again, I'm not going to walk you through each one of these individually, but you can see these cover the full spectrum of what most people could anticipate as health care needs. Hospital care, outpatient care, prescription drug care, mental health care, OB and maternity care. All of these are things that are what are called your basic benefits. And what are your benefits? Your benefits are actually a contract between you and the organization that pays for your health care, and what they pay for is spelled out specifically in those contracts. By federal mandate, all health insurance carriers are required to cover, to some degree, those 10 essential health benefits. However, there may be limits on those benefits, such as out-of-pocket costs, maximum visit limits in things like physical therapy and medical equipment. And you are going to have patient cost sharing, and we're going to go through those terms in a little bit more detail. So, what is cost sharing? Well, payers pay for most but not all of the care that you receive. The first thing that you'll be faced with, everybody know what a deductible is? Yep, a few hands go up. A deductible is what you have to pay before your insurance benefit begins to apply. And that deductible is one of those things that's spelled out in your benefit contract. Most of us can relate to auto insurance. We all know what our auto insurance deductible is. If you crash your car, you're going to have a deductible of $500 or $1,000. So when you take it to the body shop, that first portion. But in health insurance, it can be quite daunting, can it? With new deductibles in health insurance, many of them based on what employers want. That deductible can be $1,000 a person, it can be $2,000 a person, it can be $5,000, up to $10,000 for a family. So it can be quite a large chunk of money that you, me, and everybody else may have to spend before your insurance benefit kicks in. Why is that important to MS? Because your care is expensive, and every year when the new year rolls around, you may find that you have a new deductible to meet, and therefore a large out-of-pocket expense. Okay, so it's not over then. What is a copayment? A copayment is a fixed dollar cost that you pay against a service. So let's say a service costs $100 and your copayment is $10. That means you pay $10, the insurance company pays the other $90. A copayment is fixed, which means it doesn't vary by the type of service. So if the next service you get is $1,000, your copayment is still $10. So copayments are fixed based on whatever your benefit schedule is. That's different than a co-insurance, and that's a polite term to say you're going to pay a percentage of your care. Usually it's 10, 15, or 20. In Medicare, it can be up to 33% of the cost of a drug or a service is a co-insurance. So let's recap that. Deductible is what you pay before your benefit starts. Co-payment is a fixed amount you pay for whatever the service is. Co-insurance is a variable amount based on a percentage of the cost, and then sometimes they're benefit maximums, which means that the maximum amount that an insurance plan will cover towards a service is a fixed dollar amount. So, and we're not going to go into that one deeply because most of you will be affected by deductibles, co-payments, and co-insurances. Then you may find that your prescription gets bumped up against something called a formulary. What's a formulary? Simply put, it's a list of drugs. It's a list of drugs that's been developed based on the evidence at the time of what seems to be the most effective, safest, and least costly or most cost-effective alternatives. And then even within formularies, there are different types of formularies. There are open formularies, which all drugs are cost. It's just that some drugs are going to be considered preferred drugs and you pay less for them than the non-preferred drugs. Open formularies with exclusions basically is a variation on that where some drugs are simply excluded from coverage because there are equivalent drugs already on the formulary. And closed formularies, which some of you may have experienced, are those drugs that only the drugs on formulary are coverage. So did that make sense? Open formularies, all drugs are covered but with different out-of-pocket costs for you as patients. Excluded drugs are those that are not covered regardless of what, in other words, you're going to pay for those. And then closed formularies, only the drugs on a specific list are covered. I know it's a confusing group of terms. Then you may find you're faced with something called step therapy. Has anybody ever been told you have to have a step therapy for your treatment? Probably never heard of that. But basically what step therapy is in managing the drug benefit, many insurance carriers require you to have tried and failed or be not a candidate for a less costly or perhaps a generic drug. In fact, generic drug steps are probably the most common. How many people have gone to the drugstore with a prescription and gotten a generic substitution for it? Certainly almost all of us have. And those are sometimes called step therapy. Or sometimes an insurance carrier will have a particular brand on formulary and you will have to have tried or not be a candidate for that brand. And then sometimes there are guideline-based step therapies. Diabetes is the classic example. All the ADA guidelines, even up to 2019, recommend if you have type 2 diabetes starting with a drug called metformin. So again, these may be foreign terms, but these are all the things that are happening to that prescription before you ever get it from the dispensary. There may be quantity limits, which means that they will only dispense a month's worth of medication, 2 months worth of medication, 3 months worth of medication at a time. Why are quantity limits placed in there? Because not everybody can take every drug. Some drugs are not tolerated. And you may change insurance carriers at the beginning of a new year, and your old insurance carrier doesn't necessarily want to be the one to pay for a year's worth of medication when on the next day you move over from, say, Blue Cross to Aetna or Aetna to Cigna. We also know that sometimes quantity limits are put in there as safeguards, such as a maximum number of days for an antibiotic treatment so you don't stay on an antibiotic and develop bad consequences of it because you've taken it too long. Opioids are another one that we're now putting quantity limits on. It goes without saying you can't pick up the newspaper or look at the evening news without understanding we have an opioid epidemic, and so now we're putting maximum days on that. And cancer drugs are often a case where that happens because many people don't tolerate their cancer therapy, and therefore they will be dispensed in relatively small quantities until it's found out about. But again, these are all things that are happening in the background that you may have never seen. And then, of course, the one you've all heard of and you've grown to love. I'm being sarcastic, of course, the prior authorization. The prior authorization is really the mother may I, right? Which is basically your prescriber has to meet certain criteria or show that you meet certain criteria in order to have a drug approved for payment. Why do payers prior authorize these drugs? Go back a few slides and look at the cost of this and the $4 million lifetime investment, and they want to be sure that that money is being spent appropriately. On the other hand, this can be a very onerous burden to both providers and patients alike. Went through that with my son. Fortunately, his prior authorization sailed through because he happened to be prescribed a drug that was on the formulary, was a preferred drug, did not have to go through a step therapy, and he met the criteria for prior authorization. That doesn't happen to all of you out there. What's the rationale? And that's really it. The reason payers do this, they attempt to avoid inappropriate drug use. They try to use evidence, meaning the best scientific evidence, to back up their prior authorizations. They want to maximize the use of healthcare resources because in the end, really insurance carriers don't pay for healthcare, right? You pay for it by paying your premium, and the more they pay for healthcare, the more premium you pay. Your employer pays for it or your tax money pays for it. So they're trying to manage the overall medical cost, and that's why I put that in bold. Okay. So now, I have my first prescription, or I got a new prescription because my doctor changed medicine. What happens next? It depends, doesn't it? It really does depend on the circumstances of your insurance coverage. But most likely, as I already said, and I told my son when he got his first prescription, don't think you're going to walk this down to CVS, sit in the you might maybe do a little bit of shopping and sit in the chair by the pharmacy while your prescription gets filled. These drugs are considered what are considered to be specialty drugs. How many have heard the term specialty drugs? All right, good. This will be an easy part for you. How many have heard the term specialty pharmacy? If you have MS, you're living under a rock if you haven't heard the specialty pharmacy, probably. And here's a number of other behind the scenes happen. First of all, specialty drugs are high-cost prescription meds that treat complex chronic conditions like rheumatoid arthritis, MS, and cancer. That definition needs to be changed in 2019 because we're seeing specialty drugs out there now for eczema, asthma, and other chronic conditions that are not so uncommon. So specialty drugs are now probably being more defined as drugs, at least in Medicare, that meet a certain price threshold. And a specialty pharmacy is a pharmacy that specializes in, and I'm using the word specialty an awful lot here, specializes in the distribution and management of patients with these complex diseases and high-cost specialty drugs. So, as you know, what the specialty pharmacy will most likely do, because they know your drug needs to be prior authorized, they'll contact your physician to get the information that's necessary to approve the drug. That means your physician is going to have to either fill out a form, go online and do it, talk to a specialty pharmacist, or fill out a piece of paper and fax it in. Yes, in medicine, we're still one of the few industries out there that actually still uses a fax machine in not too infrequent times. It also means that the payer is going to evaluate your physician's request against their criteria. And in some, not all cases, they may have to go back to your physician for additional information. Remember formularies? We talked about formularies. It also mean the drug that was requested for you is not on the formulary, so they will be going back to the physician to say, you know, if indeed you need a drug that's not on the formulary, we're going to need additional information to justify that, or ask the physician to switch the prescription to a formulary drug. So this is all going on at the specialty pharmacy level before you get your prescription. If it's approved, the specialty pharmacy is then going to contact you, right? And they're going to get some basic information from you. They're going to, among other things, find out where they need to deliver that drug, because most specialty pharmacies are remote from you. They're not down on the corner. Now, there are big companies like CVS that own both a specialty pharmacy and local distributors, and they can ship your drug to your local pharmacy, but that's not always the case. So they need to know where to send it. Some of these drugs have sensitive shipping requirements, so they also need to be able to know, are you going to be there to receive this shipment, and not have it sit on your porch in 100-degree weather, or, as Jeff said, in the Florida 90-90 weather. And then they're going to ask for one more thing, right? Can I have your credit card number or a method of payment? Because specialty pharmacies don't ship the drug until they have a method of payment. And remember, we talked about deductibles, co-insurance, co-payments, all those things. All of those things are going to need to be met by you or another source of that. There are financial assistance programs out there, both from manufacturers and third-party foundations. But the specialty pharmacy needs verification of payment, not only of the insurance carrier through the prior authorization, but you. And then it gets even more complicated, right? This is where my son got very confused, because in the first week after he got his first prescription approved and sent to him, he got contacted by the pharmacist at the specialty pharmacy to talk about the medicine, how important it was to stay compliant, to tell him they were going to be sending a nurse to the home to talk to him about injection techniques. He then got a call from the health plan case manager talking about the same things, because remember, the health plan has that vested interest in seeing that the resources spent on your behalf are done properly. Then he got a contact from the hub, which was supposed to be a single point of contact set up by the manufacturer. The hub talked to him about financial assistance programs and all of those things. And then you may actually get a call from the case manager at your MS center. The big question I got from my son was, which one of them do I listen to? That one, legitimately, my first answer was, gee, son, I really don't know on this one, because they all may be giving you confusing information. This is one where you're going to have to go back to your MS doctor and really ask him where to go with that. But it can be confusing to you, because you're getting all these phone calls, all these people are asking you the same questions. And the reason they're all doing that is because they all have some stake in the ground in managing your care. So, as I said, this is all the stuff that happens with that one little prescription, especially the first one or the first new one. And that may happen over a period of a week. It may happen over a period of a few days. And God forbid, if your initial prescription gets non-approved or additional information is needed, it could take 2 or 3 weeks before it's all sorted out and you actually get a medication. So it's a system, like I say, it's building that car with all these disparate pieces that has grown up to be a good bit confusing, not only to you, but to your family, your physicians, and other caregivers. And so I've already talked a little bit about the timelines. Once everything is good, the specialty pharmacy can usually get your prescription to you within 24 to 48 hours. And that can, usually comes through overnight. But remember, that's not going to happen until you've paid. And I thought this little cartoon on the other side, you can all read it for yourselves, is not inappropriate for 2019 and beyond. For those of you who can't see it, what's the woman is asking her pharmacist, what's the number one side effect? And it's bankruptcy. And so summing it up, getting an MS drug is not like a standard medication. You all know that. I'm talking, I'm preaching to the choir here. Because it's an expensive specialty pharmaceutical, it's going to be handled in all likelihood, at least initially, by a specialty pharmacy. It may take some time, especially for your first prescription or a changed prescription. Expect to be contacted by an array of people, an array of individuals. And don't worry, I talked to my son just day before yesterday as he was about to leave for vacation, and we were talking about his MS care, and he goes, you know what, Dad, I'm an expert now. I think I could teach you some things about how to get medicines. And you're darn right, he probably could, and many of you have become that. But I thought it was a good idea to take the cover off this and show you all the things that go on behind the scenes. And then there's one last thing, and this talk isn't intended to go into great detail about appeals, but one thing you do have that's protected by federal legislation, state legislation, and also the certifying bodies that certify payers is the right of appeal. But you do have to know what that right of appeal is. You do have to know what the timelines are. Be sure, if you don't read any other part of your prescription benefit booklet, read the appeals process, because if something doesn't go the way you expect it to go or the way your physician expects it to go, understand the appeal process and understand the timelines of the appeal process, because there are timelines that are there. Appeals can be made by phone and writing. I suggest you just take out your insurance card, turn it over. Insurance carriers are required to put an 800 number on the back of that. When you get somebody, finally, when you get through all the prompts, right, because you're going to have to go through all those little cues, press 1 if you're a human being, press 2 if you want this in English, press, and so forth. Eventually you're going to get a live person, and that's when you say, I need to file an appeal of something that was denied in my case. And at that point, they are required again by law to walk you through and direct you through the appeals process. In fact, most payers have appeals coordinators that will then contact you to make sure you understand it. That's because, bottom line is most important, these appeals are highly regulated by state, federal, and certifying organizations. And if you don't get advised of your right of appeal and those sorts of things, they're in violation of multiple regulations. So with that, I have a minute left over, so timing was pretty good, and we have plenty of time for questions.
Awesome. Thank you. Everybody give him a round of applause. And I want to know who's going to be the first person to ask a question. Who do we have out there? Great. Thank you very much. By the way, before I even get to you to ask a question, I want to know why the insurance cards, for all that data on those cards for where you make a phone call, are in 2 font.
That's a great question. There's only so much real estate you can put on an insurance card, and there are so many things that are mandated by law that have to be on there. They wind up being in that small font. The only exception is Medicare cards, but then they don't have any information on them. They have your number.
Great. Thank you.
I would like to know why there seems to be price fixing going on. I haven't looked into the prices lately because I, at the moment, have given up on medications, but typically every single drug that was given by shots was $4,000 a month, and then it was an extra $1,000 a month for something that was a pill. And I was on Copaxone for 6 years. The first time I started it, I had a $6,000 deductible, and I paid $935 per month out of pocket for Copaxone. Now I don't think it's ever sold for anything less than $4,000 a month, and they're all the same.
Well, you make a good point.
Thank you.
The only thing I can say, we still live in a free enterprise world where you can, as a manufacturer, charge what you think is the appropriate competitive price. Now, how those prices are derived is beyond the scope of my knowledge because I don't work inside those who set the prices. All we can do as payers and the public is respond to those prices. I wish I had the methodology, but that's not my knowledge base. But I will give you an anecdote, and that anecdote is how I got into MS work in the beginning. Was I was working at the health plan back in 1991 when the first beta interferon was first launched, and it came out with what was then the virtually unprecedented price of about $8,000 a year, not a month, a year. And the pharmacy benefit world was turned upside down with a drug that expensive, and it was felt we had to do something to manage, are the appropriate patients getting it? So you can see how we've evolved in just a few short decades.
I can't run. I used to run, but I can't run anymore.
You're
it's
not
quite
alone
obvious
in
by my midsection, all right?
I don't know really if this is a question or a two-part statement. If the manufacturers are, let me put it this way, why does it seem that the sacrifices and the challenges are placed more on the patient dealing with the problem? So instead of putting more effort in mandating and regulating the pharmaceutical sellers, it's passed on to the people who need the medication. So why do you think that is? And the other part is what concerns or cautionary measures would you tell people who deal with Medicare and Medicaid?
Yeah, the first question certainly is one that's been, besieging our Congress for a good bit now, and that is, why do we pay more for drugs in the U.S. Than virtually, well, not virtually, than any other, industrialized nation? And, a lot of that has to do with the fact that we do have We don't have a single payer system. We don't have the bargaining power at the governmental level to do those kind of things. And the regulations that were written for the CMS, right, Medicare, were written in two time periods, right? The 1960s for your basic benefits and the 1990s, or actually just after the turn of the new century for your drug benefits. So those regulations are outdated, and you're right. Unfortunately, it puts all of the burden, on the patient. But on the other hand, I will tell you, there's probably no better advocate for your own care than you as the patient or your family members. I think the second part of your question, can you please repeat that? Because I sort of lost the context in entering.
Okay, when you're using Medicare, let's say, for example, Medicare and Medicaid, don't you have to, I've been told, for example, that if you're caring for a loved one, they pass, and you've utilized Medicaid, you could be responsible for paying back whatever they gave you.
Yeah, that's true. Well, that's true for any governmental program, that if you are otherwise no longer entitled to whatever that benefit is, and death is certainly one, yes, you're obligated to notify the appropriate agency, whether it's Medicaid, Medicare, or Social Security, that individual has passed, and that they do have legislatively or statutorily the right to reclaim any benefits paid that were paid after the date of death. So yeah, you do have to be careful with those sorts of things, that you're aware of that need to notify. Likewise, with Medicare and Medicaid, when you're dually eligible, there are a lot of special programs that you are eligible for that decrease your out-of-pocket spending on these drugs, so that you don't have to meet some of those large deductibles or co-payments. So you need to be very aware, if you're a dually eligible beneficiary, that you have the ability to get a much richer benefit for most of these products.
For example, I'll use my mother. If she receives a benefit and I have in-home care come for her, she passes. Whatever Medicaid paid for, once my mother passes, so let's just pick a number, $50,000 they gave to her for in-home care. Now she passes. The family, responsible parties have to pay that $50,000 back.
That one I'm not aware of. Okay.
So that's what I was asking.
Yeah.
This was something that was rumored, and I just wanted to make sure before I take.
I'm aware of. Because they don't pay the money proactively up front. They pay it at the time of service. Now, if they continue to pay for services that weren't given after the time of death, yeah, they're going to recoup that. But they're going to recoup that from the organization that continued to bill it, not the individual family. The scenario you paint is one I've not seen.
Next question's here.
Hi, this isn't really a question. I just wanted to thank you very much for the way that you presented the information. I think it was really thorough, and it was a lot easier to understand than reading in the booklets.
Yeah, the booklet is a good cure for insomnia. It's also a one that will send you to your lexicon to look up different words that you've never seen before. Insurance language can be quite tedious at times. And I think probably the best resource that's out there that's publicly available is actually from Medicare, right? How many of you have gotten your copy of Medicare and You, which comes out annually, right? That's probably the best, but how long is it, right? It's about this thick. Again, how many of you have read Medicare and You cover to cover? Next question. How many of you have gotten 8 emails in the last month asking you to sign up for it electronically so that they don't send hard copies? Yep.
Great. Any other questions? I need to run. You see, I got to get rid of this, remember? No? Well, let's thank Dr. Owens for being here today.
Well, thank you for inviting me. It's a lovely audience.